Thank you, Dr. Thank you, Dr. Samet. So that's actually a great segue because our next speaker is Dr. Sandro Galea, the Dean and Robert A. Knox Professor of Boston University School of Public Health. And he'll be speaking to us about the epidemic, the opioid epidemic in context on mitigating the epidemic and preventing the next one. Dr. Galea.
Good morning. Thank you for having me here. It's always slightly scary to be talking about drugs when Professor Samet just said this is the best place in the country to study drugs, which I agree with, actually. So I fully expect that you will all be able to say much better than what I'm going to say, but somehow they asked me to speak. So I am really here to just ground us in the epidemic. And ahead of this terrific day, the idea is to just give us all some data about what really is going on and to ground our thinking. And then as I see Commissioner Burrell speaking about how we're actually trying to prevent the epidemic, and I'm sure Dr. Volkov is going to talk about translational efforts, hopefully this gives us the foundational data that can serve as glue to all that. So having said that, let me plunge right in. I'm really only going to make 5 points in my brief time here. But let me start with the opioid epidemic. So there's no question that this is the epidemic of our time. And just to ground us a little bit in the scale of that, this is the red line is drug overdoses going up, and we're now at about 65,000. What I like about this figure is that it shows how the opioid epidemic, the peak of car crashes was in 1972, which we passed over there. The peak of HIV was in 1995, we passed over there. Peak of firearm homicides was over there, so we passed it. So the opioid epidemic today is bigger than the peaks of the car crashes, HIV, and firearm homicide epidemic. And there are many, many things that make the opioid epidemic truly deeply sad, but one of the things that makes it truly deeply sad is that it's affecting principally people in the peak productive years of life, in the ages of 25 to 55, right? So this is a graph about opioid-involved overdose deaths, and 25 to 55 is really the peak years for this. Now, having said that, I think it's important to recognize that it is not just those years. And in fact, the opioid epidemic is affecting all age groups. This is actually all age groups, and what you actually see is over time, again, you see an increase in overdose deaths in all age groups. Now, one of the things in the public conversation is that the opioid epidemic is certainly in part reflects a global phenomenon, which is also true, but it's important to recognize that this does reflect sort of an American exceptionalism. We are worse off than all other countries. When you look at other countries, this is us, this is the US, and these are all other countries. These are all other countries actually going up in terms of percent of deaths that are drug-related, but we are much ahead of everybody else. So this is very much a problem of our time, and it is very much an American problem. In fact, in the United States, the average days of opioid use per resident is higher than all other countries, and the standard daily opioid dose is higher than all other countries. So we have more opioids, more dose, more days per person than all other countries. So this represents very much an epidemic of our time and very much an American epidemic over and above everybody else. So that's point one. Point two, let's talk a little bit about geography of the epidemic, because I think it's important to actually reflect geography of the epidemic. The first slide by grounding is this, which I actually think is an extraordinary slide. This is by year, this is 1999, this is 2015, and my challenge to you all would be not to look at the title. So don't look at the title overdose deaths and replace that scary infectious disease outbreak, right? So if this was called scary infectious disease, look at that. Right? You know that we would have been clamoring for a treatment, for a vaccine, for some drug. Like, we wouldn't be waiting till here, like over here, like ignore all this, right? 2009, if this was called scare infectious disease, we would have done a lot more than we're doing because this is opioid. So I actually think this is a remarkable slide. I actually haven't had the opportunity to do it, but one of my intentions is to present the slide to a class of students and actually cover the title and ask them to actually say what they would do to mitigate this kind of epidemic. So it's an extraordinary picture. There's been a lot of discussion about the geographic distribution. The opioid epidemic is now mostly rural areas, predominantly over large metro areas. It wasn't always like this. It started off with large metro areas, but then rural areas did overtake. The current picture, this is today, of drug overdose deaths, it's not evenly distributed around the country. New England, where we are, is a site of real concern, as is more or less the Southwest. So that's actually where we are at today in terms of the geography epidemic. So point A, the epidemic of our time. Point B, it has particular geography. Point C, We refer to this as the opioid epidemic. It's actually not true. It's actually incorrect to call this the opioid epidemic. I think there are 3 separate epidemics, and I think it's important for us to recognize that because it has implications for how we think about it, how we think about how it's evolved, and obviously how we think about mitigating future epidemics. There really are 3 epidemics with 3 different causes. The first cause, as I think everybody here knows, really emerged from very I'm choosing my words carefully, largely well-intentioned prescribing of opioids to deal with perceived undertreatment of pain. So the first part of the epidemic really was driven by physician prescribing. And the first part of the epidemic was we're selling legal opioids, which resulted in increased sales and increased deaths. That's the first part. The second part of the epidemic then became heroin. That simultaneously the price of heroin went down. And the heroin then replaced what we started seeing in a lot of opioid deaths. So first was medical prescription of opioids. Second was heroin. And then the third phase of the epidemic, which is where we are today, is synthetics. And this is prescription opioid use. You can see it here. And this is the heroin and fentanyl, with fentanyl being the latest spike in the past couple of years. So really, although we refer to this as the opioid epidemic, it's very interesting sociologically because we've gone from prescribing to heroin to synthetics. And today, what is driving the epidemic today, what's driving the uptick in the past year, there's no question it's the synthetics. This is the opioids most commonly involved in overdose deaths, just comparing 15 and 16. That's any opioid. Look at synthetics right here. So synthetics have essentially doubled. Heroin has increased a little bit. Methadone's the same, natural and semi-synthetic is there. So it's really synthetic opioids that are driving the epidemic today. And when you look at drug seizures, this is fentanyl in 2016. This is how much fentanyl has actually gone up. So it is not really one epidemic. It's really 3 epidemics. Started with physician prescribing, moved on to heroin, moved on to synthetics. And of course, many synthetics today aren't even manufactured domestically. They come from Asia because they're very easy to ship. So there are multiple different forces, geopolitical forces, that are actually now continuing to fuel the epidemic. So third point, 3 epidemics. Fourth point, that this happened, that we allowed this to happen, really comes against a backdrop of what else is going on in the country. So let me start, first of all, with the biologic backdrop in many ways. The biologic backdrop is that we're dealing with drugs that are highly addictive. We're dealing with drugs that are highly addictive. This is I like this slide. This is the risk of continued opioid use. This is number of days in the initial opioid prescription, and this is continued likelihood of using opioids at 1 year, continued likelihood of using opioids at 3 years. So obviously this is lower than that, but look at this. The more days with the initial opioid prescription, the more likely it is that you're going to continue using opioids. But the risk of the likelihood of dependency spikes in the first week, right? So prescription for 30 days, you have a 40% likelihood of continuing to use opioids a year later, right? So it's really, it's a highly addictive substance. So it's part A of the backdrop against which this epidemic has evolved. Part B is that actually we have been increasing collectively as a country the mental behavioral disorder disease burden. This is DALY's, Standardized Disability Adjusted Life Years. That's 1990, 2015. Mental behavioral disorders, which I've put on top, that's where they were in 1990, that's where they are 2015. So mental behavioral disorders now account for more disability adjusted life years than cancer, circulatory injuries, etc. So there is a backdrop of increasing prominence of mental behavioral disorders across the country, and this is years lived with disability. Again, that's mental substance use disorders and then musculoskeletal disorders. So in terms of years of life that are now lived with disability, where people have functional impairment, mental behavioral disorders contribute much more than any other disorder, second being musculoskeletal disorders. Some of you may have seen these things. Musculoskeletal disorders, principally, by the way, is back pain. So it's on a backdrop of an increasing significance of mental behavioral disorders, and when I say that, the problem with saying that to a room like this is that you're all in this room because you actually all care about mental behavioral disorders. The problem is how much do we collectively in health care about mental behavioral disorders? And in many respects, if one were to use the very, very crude metric of saying we should map our interest with the burden of disease, well, we should be mapping our interest with burden of disease, which means we should be more interested in mental and substance use disorders than in any other diseases, which of course is not the case. Mental substance disorders get far less attention than do many other disorders. And now the other part of the backdrop is that despite this, substance use disorders remain extraordinarily undertreated. They are extraordinarily undertreated. So this is a receipt of substance use treatment in a specialty treatment facility in the past year, people over age 12, among people who need it. So 90% do not get it. So only about 10% of people who could actually benefit from substance use special treatment get it. Now, there are many reasons for this, and I'm not going to spend the whole presentation talking about that, but one of the biggest reasons is that people do not think they need treatment. And this is about only 5% of people actually perceive a need for treatment, which is really quite extraordinary, right? If you think about it, I actually don't know the data on this, I should find it, on things like back pain, right? So I showed you years of life lost is number one is substance use disorders, number two is musculoskeletal disorders. But I am sure that the percent of people who think they need treatment for back pain is, oops, I'm gonna go back, is much, much larger than 5%. So I think it's actually really interesting. It's interesting sociologically, but I put this up there because I think this is the backdrop against which the epidemic has developed. We had here the Surgeon General who did a panel with Commissioner Burrell, and one of the questions that we kept asking is like, why did it take us so long? And I actually think it took us so long for us to be having these kind of conversations for many, many reasons, including the reason that frequently for substance use, we do not think that treatment really matters. And people do not, as a result, go to treatment. So that's point 4. Point 5. I know it says 4, but I misnumbered. That's actually point 5. Sorry. I wasn't trying to pull a fast one. I realized as I was looking at the slides, I'm like, oops. I was trying to make 5 points, but instead I'm making 6. I apologize. Forgive me. This is a very brief point, don't worry. This is very costly. It costs us a lot of money. It costs us money and it costs us lives. So I'll show you first of all the money. This is the best government. This is from the Office of Management and Budget. There are many different costs of the opioid epidemic, but their cost is about $500 billion a year. That's their best cost. This is a low estimate and a high estimate. There are multiple academic papers that are written about this, but $500 billion a year is what the federal government is using, which just by way of grounding is about 3% of GDP. Right, so we talk a lot, we as a health center here, we talk a lot appropriately about the rather ridiculous overspending on percent of GDP of healthcare. Healthcare is about 18%. That's fine, but actually 3%, leaving that aside, we're actually spending 3% of GDP on this opioid epidemic, which is actually really extraordinary when you think about it. So there's a financial cost, but there's also a deep human cost. There's a real deep human cost. And I think this slide actually captures the human cost. It's from a paper in JAMA that just came out recently. What this is the contributions of causes of death to life expectancy. And the way to read this graph is bars to the right, it means that we are actually increasing life expectancy due to a particular disease. Bars to the left are we're decreasing life expectancy. So look at this. So we are getting better at heart disease and neoplasm, right? So we're increasing life expectancy as a result. We actually are increasing life expectancy as a result due to everything except unintentional injuries, Alzheimer's, suicide, and this now breaks down as opioid and drug poisoning. So really the areas, there are really only three areas where we are chipping away at life expectancy. One is neurodegenerative disorder, Alzheimer's bucket. 2 is unintentional injury, and much of that is guns. And 3 is opioid dependence. Those are really the 3 areas. It's like we're doing well on everything else, but we're doing poorly on these 3 areas. And we know we're doing poorly in these 3 areas. There is no mystery. I mean, we have it right there. And as a result, it means that we should be paying more attention and doing something about that. So this has a real cost. It has a real cost to us. It has a real cost both in terms of money and in terms of human lives. And my last point, this is my last point, which is at the end of the day, all of this ultimately comes on a backdrop of the foundations of how we have structured how we deliver health. This is those of you who are in our community will have heard me say this many times before. I apologize, but I will keep saying it many times. We are terrible at dealing with our health. We invest more in our health than everybody else, and we get less out of our health, and we think that somehow that's acceptable, which in fact it should not be. So this is my favorite slide in the whole world. This is money we spend. This is life expectancy. So you see all the rational countries in the world, you spend more, you get more life expectancy, but not us. You see, we're off the chart. So I don't know how many of you are in the pediatric arena, right, when you have pediatric growth charts, right, and then you have the child, like, she starts falling off the growth chart and it says she has failure to thrive, right? That's us. Look at us. We have failure to thrive. That's it. It really is like that. And why is that? And that's the subject of many conversations, but my favorite explanation why that is comes in just one slide. I'll show you the slide. Here's a slide. You can't read the rows. I know that's intentional, actually. The rows are countries. That's all I'm going to tell you. And there are 2 bars here. There's a blue bar and the red bar. The blue bar is money spent on medicine, on healthcare, treating people once they're already sick. The red bar is money spent on the conditions the social, physical world around us that can actually keep us healthy. And when you look at this graph, you know exactly which one the United States is, right? The United States is right there. You see it? Bigger blue bar than everybody else, red bar roughly the size of Mexico. That's us. That is roughly what we are doing. And in fact, you know, I made a reference initially to American exceptionalism. I don't know if people caught that, but I was presaging this slide. This is American exceptionalism. This is the difference in our life expectancy compared to other high-income countries, other OECD countries. So we actually were gaining in life expectancy, blue, better, than other OECD countries all the way to like 1990, you see it? And now we have been losing in life expectancy since 1990. So that's, 1990 was what, 35 years ago? No, 25 years ago, sorry. It's actually sad, I remember 1990 well. But since that time, we've actually been doing worse. So the only good news about this I have is that we actually are doing this to ourselves, and we've done it to ourselves in a short period of time in 25 years, so hopefully we should be able to reverse it in the next 25 years, of course, if we decide to do it. I will end with a quick story and a metaphor. This is one of my favorite stories to sort of explain why it is that when we do things right versus when we do things wrong in health. This is a bluesman. His name is Blind Willie Johnson. Blind Willie Johnson was born in Texas at the turn of the 20th century. And he was born sighted. And the story is that he was blinded at age 7. His stepmother threw lye in his face in a domestic violence incident, so he was blind. So he was blind, poor, in Texas in the 19-teens, 1920s, 1930s. He learned to play the guitar. He made a living busking, which is how we remember him. We actually remember some of his songs that way. But not a very good living, as you might imagine. He got married, and he was living in a small house with his wife, and his house burnt down. And his wife and him didn't have any money, so they kept living in the burnt-out husk of the house. When he was in his early 40s, Blind Willie Johnson got malaria. And his wife took him to hospital, and he was turned away from hospital, and then he died. It's not clear if he was turned away because he was poor, because he was black, because he was blind, but he was turned away. So the question I ask is, what killed Blind Willie Johnson? Well, what killed him was malaria, right? What killed him was malaria. I mean, malaria physiologically was killed him. Had he taken some chloroquine, he would have lived. But when I tell that story, everybody knows that did malaria get him that day? Something else was going to get him the next day. Pneumonia would get him the next day. If pneumonia get him the next day, injury would have gone him the next day, right? Because it wasn't just malaria. What killed Blind Willie Johnson was malaria. It was also poverty. It was racism. It was homelessness. It was domestic violence. Those were all the factors that killed Blind Willie Johnson. And ultimately, the opioid epidemic that we have now, yes, it is a medical condition, but it is ultimately sitting on a whole host of social and economic conditions which we often neglect. And ultimately, yes, we need to deal with the medical conditions, the opioid epidemic, but if we do that just in isolation, we will keep failing. That's it. Thank you very much for having me.
So we'll ask for questions. This time we're going to use microphones because we are live streaming and we want people to hear us. So, questions? Dr. Center?
Every map of opioid overdoses has this big hole in the middle of the country.
Yeah.
What can we learn from what's going on there? Is it genetics? Is it EMT, early responses? What's going on there?
Well, unless you're going to make an argument that the genetics of Michiganders is different than the genetics of folks from Massachusetts, I don't think it's genetics. Unless you're going to make an argument that EMT in Michigan is much better than EMT in Arizona, it's a hard argument to make. So I don't think it's either of those. It must be the set of circumstances that fuel the epidemic. So again, I think we need to think of it as the three different epidemics. There was the prescribing epidemic, the heroin epidemic, and then there's the fentanyl epidemic. These are three, in many respects, they're three different epidemics, even though the outcome, which is opioid dependence and overdose mortality, ends up being the same. So I think the full analysis would need to be looking at all those three epidemics in those three areas, as well as the backdrop to the epidemic that I talked about. So I don't know enough about it, and I would welcome other people from the audience, but I think it's an interesting question. Yes.
Me?
Yeah, sure, and there's somebody behind you afterwards. It's fine.
In reference to the chart that you showed that overdose deaths in rural areas have increased and basically overtaken the overdose deaths in the more populated areas,
Yes.
the metro. I'm guessing that is because less access to treatment in the rural areas and less access probably to Narcan.
Yeah, it's a good question. I think it's much more than that. There's been quite a bit written. The language that has emerged from economics, for better or for worse, is that these are sort of a bucket of diseases of despair, that ultimately socioeconomic stagnation is fueling substance use dependence, which is then, of course, fueling the opioids and opioid overdoses. I'm not sure if that's all it is. I really think that there's a very complex causal architecture what's going on. I do think that there is socioeconomic stagnation. I do think that it's also lack of access to treatment. I do think that it's in particular, many of these rural areas have, the epidemic has really skyrocketed once it went to the synthetics, to heroin and the synthetics, et cetera. So I think it's a combination of everything. Unfortunately, none of this has a simple single answer. One more question there?
There was a study about perceived need for treatment, and how do you determine the need for treatment if if the use hasn't come to a point where it has caused problem for the person themselves? So how is that need determined?
Yeah, no, it's a very good question, and of course the operative part of your question is problem. The question is, what is problem? And there are multiple, you said it hasn't caused problem for the person himself. There are multiple different ways diagnostically of assessing problems. I think the challenge is that we, and I do mean we collectively as humans now for a second, we misperceive the extent to which behavioral disorders cause problems. We think they're not causing problems when in fact they are causing problems. And I think that is a common in our national conversation about health, which is different than other countries. It is different than other countries. We remain a country where we consider mental diagnosis, mental illness of any kind, largely disqualifying for our elected officials. We are in a country where we consider mental disorders largely disqualifying for CEOs of large companies, right? And so that is very much the tip of the iceberg of how we think about this. I think until we move beyond that, until we recognize that a behavioral disorder is treatable, curable, manageable as much as is a cardiac disorder, as much as is a neurological disorder, as much as is a hepatic disorder, I think we are always going to keep stumbling on this issue. Okay. Very good. Thank you for having me.